When most of us hear the word kappa these days, we more than likely immediately start thinking about SARS-CoV-2 variants and try to remember how important this particular one was in the grand scheme of the pandemic. But that is not the kappa that we'll be talking about today. Instead, we'll be discussing the other kappa, which stands for COVID-19 associated pulmonary aspergillosis, or CAPA. And we'll cover a few areas on this topic today, including defining what kappa is and how prevalent it is amongst ICU patients with COVID-19. We'll discuss why identification of invasive aspergillosis in patients with COVID differs compared to other at-risk patients. And then we'll review two recent publications in JCM that discuss specific assays and diagnostic approaches for optimal detection of invasive aspergillosis in COVID-19 patients. Welcome to Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and also on Twitter at jclinmicro. The podcast is supported by the American Society for Microbiology, which publishes JCM. And we ask that you please subscribe to this podcast and leave a rating or review wherever you get your podcasts. I'm your co-host, JCM editor Ellie Thiel, and am joined by JCM editor-in-chief Alex McAdam. Hey, Alex, how's it going today?
Ellie.
Hi.
I'm fine. I'm really excited about the topic. As I mentioned to you, we haven't done a lot about mycology on the podcast, so I was really excited when you chose these papers.
Yeah, I'm excited. And we have some, experts in the field of clinical mycology today, both of whom have published on CAPA recently in JCM, and you can find the links to their papers below. But our first guest for today is Dr. Martin Hohengil from the University of California at San Diego, and also from the University of Graz in Austria, where he currently is, I believe. So hi, Martin. Can you please introduce yourself briefly for our listeners?
Hi, Ellie. Hi, Alex. First of all, thanks for having me. So my name is Martin Hohengil, and I'm currently associate professor at the Division of Infectious Diseases and Global Public Health at the University of California, San Diego, and have a double appointment and also actually associate professor at the Division of Infectious Diseases at the Medical University of Graz, Austria. And really, my main interest, and I mean, of course, I'm working broadly in infectious diseases, but main interest for a long time has been mycology and clinical mycology. And that's really also my main research interest and my main research over the last years. And really, kappa has been a big part of my research over the last 18 months. So very excited to be here and have some discussions about kappa.
Great. Well, no, we're excited to have you on. And also our second guest for today is Professor Aljandre Alonzo from the University of Paris and the Institut Pasteur in Paris, France, where it is also currently 7 p.m. tonight. So hi, Aljandre. Again, thank you for taking time from your evening to talk with us. Can you also briefly introduce yourself?
Yes, thank you. Thank you very much. And I really appreciate your invitation to participate to this very interesting podcast. So I'm Aljandre Alonzo. I'm working at Université de Paris, where I am heading the laboratory of mycology and cytology. I am also involved in basic research at Institut Pasteur, where I'm doing some basic research on the biology of Cryptococcus performance, and so on the part of my activity at the hospital. I am doing some translational research, mainly focused on invasive fungal infections.
Great.
And so kappa is one of the most important invasive fungal infection from the last 18 months in our field. And so this is why I'm also involved in this.
Great. Thank you. So, with those introductions, I think we'll just go ahead and dive right into our topic today. And Martin, I'll turn to you first. So can you just kind of refresh us on what exactly kappa is, and also talk about its incidence amongst hospitalized patients. Speaking from my own institution, we really haven't seen too much of it here in Rochester, Minnesota, but I know that's not the case elsewhere. So kind of curious about your thoughts on incidence and prevalence.
Yeah, very happy to do so. So actually, I think kappa really came first to our mind relatively early during the pandemic in May or June, actually 2020. And actually, the other guest here, Aljandre Alonzo, was a vital part of this because he came up with the first publication and the first announcements on Twitter that he was seeing this relatively often in his hospital. And then I think a lot of other centers, first from Europe, but then also from other parts of the world, came up with reports about COVID-associated pulmonary aspergillosis. I do think it's important to consider this a little bit different from the invasive aspergillosis have been seen before, and I'll come back later to that during our talk, why I think it is actually an own entity. In terms of frequency, I think it's very important, Ali, as you said, it's not the same frequency everywhere. This is not specific only to kappa, right? It's also when we think about ICU in non-neutropenic patients, invasive aspergillosis, also there probably the frequency is not and the prevalence is not the same across institutions. I don't see this big difference between continents. I more or less really see differences between institutions, and there's various reasons for that. Why it could have to do with local epidemiology, fungal exposure, genetic risks, multiple different things that really explain this. And of course, last but not least, also diagnostic approach. How aggressively do you diagnose and screen for kappa? Which may also explain, but it's really a multiple potential explanations for that. But if you really look now, and the other thing, of course, in the beginning, is also important to emphasize, we encountered this new disease entity, but we did not really have criteria to classify disease. And the result was, of course, everybody came up with their own classification because there was just no classification available because COVID, we saw this disease in patients with really COVID as their own risk factor. That's the only risk factor for developing aspergillosis. And with this fact, they could not fulfill conventional criteria that we are having for defining aspergillosis, meaning the ERDC criteria, which really requires typical known host factors for fulfilling disease. So that was in the beginning, obviously, a reason why the prevalence was different. I think right now we have a really good feeling about the median prevalence, specifically in ICU patients on mechanical ventilation. There have been really 3 or 4 large studies in the US, but also in Europe, multi-center studies. And they all came up basically with incidence between 10% and 15% among mechanically ventilated patients in the ICU with COVID-19 who are in the ICU because of acute respiratory failure due to COVID-19, and to also get screened for kappa, right? I mean, that's always important to emphasize. If you don't search for it, it's not something that you will find by luck, or even when you just look into serum samples, you may find it only very late. Or so it's really aggressive diagnostic approaches, ICU patients with COVID-19 associated respiratory failure, and there you may find it in 10 to 15% according to the last larger studies. But that said, nevertheless, when kind of like this was dissected between the different ICUs that participated in these multi-center studies, it became very obvious that this is the median, but there is a wide range, and the range can very well be between 2% and 30%. So at the end, there is still a wide range that may have multiple explanations. It's not just one explanation, I think, why we're seeing this wide range.
Do you think that use of corticosteroids might underlie some of the regional or institutional variability in the prevalence?
That's a very good comment, Alex. So actually, we know also in the meantime, we know a lot about the risk factors associated with kappa. And as you said, dexamethasone is one of the major risk factors. And we also know that, even now, some institutions use higher dose, longer term dexamethasone versus others. So that's still the case. It was particularly the case during the early phases of the pandemic, when we did not have, guidelines, universal guidelines, and good guidance on what to use. The second part, I think, is tocilizumab, right? And it becomes more and more clear. And it's interesting because these large studies really were pretty much in line what they found as risk factors. And particularly the combination of tocilizumab with dexamethasone seems to be a risk factor. At the same time, of course, we have studies that we know this is benefiting our COVID-19 patients in the ICU, right? So I'm not saying we should not use these drugs. We just need to be aware that these are risk factors. this pose some risk for patients to develop COVID-associated pulmonary aspergillosis. And the others, obviously, are older age. I mean, older age turns up a lot. Mechanical ventilation, obviously, we mostly see it in mechanically ventilated patients. But this may definitely contribute as well, and may really have contributed in the early phase of the pandemic, where some ICUs really used that broadly, and potentially also more ICUs in Europe use broadly very aggressive approaches with drugs they hoped they would help, were helpful, but where we did not have studies at this time point that actually tocilizumab or dexamethasone would be helpful. But for example, in Graz, I can tell you from the beginning on, from March on, patients received dexamethasone tocilizumab from March 2020 on. So that may definitely add to the explanation why we saw differences in the prevalence.
Thank you. Very interesting.
So, there's COVID associated, but there's also influenza associated pulmonary aspergillosis. Are there similarities between these two when it comes to diagnostics and pathogenesis?
I think there are some similarities, but at the same time, these are also different, right? So similarities is obviously, both patient groups are in the ICU when they are at risk for developing this disease, right? We know from influenza-associated pulmonary aspergillosis that they often develop this infection very early. They may even come to the ICU and already have aspergillosis. And that is also one of the reasons why it's much harder to manage, because we can't effectively treat very early, or, even prophylax, because a good proportion of patients with influenza and aspergillosis develop this very, very early, even on day 0 at the time of ICU admission. And they also have more often positive serum galactomannan, which of course fits into the whole area, because we know in ICU, in non-neutropenic patients, aspergillus is not just one infection. It's really different depending on the patient population. And in non-neutropenic patients, usually we know that it's growing airway invasive for a while, and then at one point becoming angio-invasive. While in neutropenic patients, classically, it's becoming angio-invasive much sooner, right? So it's kind of like a different disease mechanism, different radiologic findings, different diagnostics. And influenza, it also seems that it's becoming airway invasive much earlier, as angio-invasive much earlier. That's why it's more aggressive. It's earlier, and it's also having more often positive serum galactomannan positive. But yeah, apart from that, I think when both are respiratory viral diseases, right? Both can cause acute respiratory failure. So there are also some similarities, also in terms of immunological mechanisms that are similar, and then there's also some differences between COVID and influenza.
Got it. Thank you. So kind of diving into your paper, you do have a manuscript out that came out, I think, just in January, that really looked at the performance, I'd say, of a somewhat still newer lateral flow assay for detection of Aspergillus galactomannan. Can you kind of briefly talk about what the benefits would be of a lateral flow assay for galactomannan testing, and then the approach you took to evaluate this assay in CAPA patients?
Yeah. So one of the reasons we looked into this assay is that we have now, since late 2020, actually early 2021, we do have now consensus definition for COVID-associated pulmonary aspergillosis. And obviously the ECMM, where Aljandre and I am involved, was part of that, but also the ASM. So there were really multiple societies that were part of these consensus definitions. And obviously they came up with a consensus. We came up with a consensus at a time where we did not have a ton of evidence, but we just saw the problems that everyone is using different definitions because there are just not any applicable definitions. So we needed to come up with something to unify the field. And I think it was important because we also saw that, the rates actually dropped closer to what we have been seeing at autopsy series. So it really resulted in a reduction of the incidence of COVID-associated pulmonary aspergillosis just using this criteria. So they're more stringent than what have been used before. But at the same time, of course, they're not perfect because not all of that is based on evidence. One of the diagnostic assays that also recommended in these consensus definitions is the lateral flow assay. And that's basically based on a number of recent studies that have shown, particularly for BAL, but also for Serum, that this assay is performing well and comparably to the galactomannan ELISA, which is, of course, very attractive and important, specifically from a worldwide perspective, because the LFA is basically a point of care test. that can be performed in rudimentary facilities. It allows for single sample testing, right? So it's really a test that's available to a much broader audience in the world. And even for the US or for some centers in Europe, I have to say, where you don't have a ton of galactomannan screening, where galactomannan may be a sent-out test where you wait for a week or so for test results. This test could also be, a very valuable alternative to really provide you with a quick information and decision on what to do with your patient. So that's the reason why we really wanted to evaluate this test. First of all, because it was in the consensus criteria, but it has not been really validated in CAPA. So there was for us the big need to validate this test here. And second of all, because it's just such a valuable test for, from a worldwide perspective and for the mycology world, actually, beyond Europe and the US. So that's basically, I think, our main objective here. And of course, we also wanted to evaluate different sample types, right? Because we know that's also a big topic. Obviously, I'm really proposing, that the best diagnostic sample for diagnosing CAPA is obviously BL, right? I mean, that's really where we want to go. But at the same time, we know, especially during the early phases of the pandemic, we hardly basically got BL because there was always the fear of the transmission of the virus. So many centers only got tracheal aspirate or a non-directed lavage. And that was really used in the beginning. But it's still the case, when you talk to different ICUs across the world, that not every ICU is getting a ton of BLs. And I just gave a talk in Ghana, for example, in Africa, basically a virtual talk 1 week ago. And basically, for example, in Ghana, nobody's getting BLs. So they really have to use other respiratory specimens. That's why we also thought it's important. Of course, in Austria, in the US, we get BLs. So that's the way to go for us. But it was important for us to also evaluate other respiratory specimens and see, if they are of any value to test these other respiratory specimens.
Yeah, no, I agree. That was the big concern early on was, should we be doing BALs in these patients? So for your study, you looked at BAL, tracheal aspirates, and non-broncho alveolar lavage samples. So can you talk about how those performed specifically when you compared patients with proven or probable CAPA versus no CAPA? I know there's a possible CAPA category, but it's a little iffy. so focusing on like the real CAPAs, how did the results look?
Thanks, Ali. So I have to kind of emphasize that, the possible category is a little bit less iffy now with the CAPA consensus criteria, right? Because the possible category also requires mycological evidence, right? So that's kind of the big difference to the possible criteria that we are used to from our ERTC MSG criteria, where it's really basically only host factors and some clinical findings. And I really think that, in the ERTC criteria, potentially a big proportion of the possible cases do in fact not have aspergillosis. I think in CAPA it's a little bit different, right? Because the possible category may be for many centers the only category they can fulfill. Because if you don't have BL, basically it's impossible to get a probable according to the new consensus criteria, except you have non-directed lavage. But even that brings you mostly, except it's very highly positive, into the possible category. So I think for many centers, I think possible is more valuable. And it also requires combination of at least two different low-level mycologic evidences, basically to fulfill the criteria, for example, from tracheal aspiration. So I think it's, it's not probable and it's not proven. I'm totally with you here, but there is some mycological evidence and often some combined mycological evidence for the presence of aspergillosis.
Okay.
That all said, but that all said, of course, I agree. We have to go with the stronger diagnosis, and strong is definitely probable and not much strong is proven. Obviously, proven in COVID patients means the patient is dead. Basically, that's what unfortunately proven means. This was mostly autopsy proven, right? This is very rarely proven while patients are still alive. So it's just, fortunately, not the standard, obviously, because we want to diagnose people earlier and, get them out of the ICU alive. So probable is the biggest proportion. And when we think about these two categories, I have to say, and that was also surprisingly, when you just look into the areas under the curve, so the general performance, this was pretty much interchangeable between tracheal aspiration, non-directed bronchial lavage, and BL. What became obvious, of course, as soon as we used basically some cutoffs, that the tracheal aspiration is much less specific, even when increasing the cutoff to above what we use for BL. So you would probably need to increase the cutoff for tracheal aspiration for galactomannan much more for it to really become specific. But at the same time, tracheal aspiration is really sensitive, right? So if you have basically a patient with kappa, tracheal aspiration, galactomannan will be positive. But, it may also be positive in a number of patients without kappa. And the deeper you go, I think with NBL and BAL, this was in our study pretty much interchangeable, which may also have to do that we had a 3-center study, basically, multi-center study, or even 4 centers with Cardiff, the UK, and Madrid and Graz, and basically Rennes in France. So it was different centers from across Europe who were participating. And all the non-directed bronchial lavage samples were originating from Cardiff, from the UK, because that's the only thing they do basically in the UK, or did at this time point. They did not do BLs, they really did only non-directed lavages. So that's, of course, a confounder. But with that confounder, basically, it seemed that, these 2 sample types, non-directed bronchial lavage and BL, directed BL, were pretty much interchangeable and, showed all, I think, rather, promising performance. Not perfect performance, as we know from galactomannan, right? Neither in terms of sensitivity nor in terms of specificity perfect, right? So we are always in this range, 70 to 80%, depending on the cutoff, in terms of sensitivity and specificity. But nevertheless, I think, good performance and helpful tests to really diagnose kappa early.
I have a very basic question, Martin. You mentioned that shifting the cutoff would change sensitivity and specificity, of course, characteristic of any quantitative test. But this is a lateral flow test. So how is a lateral flow test made quantitative?
Such an important question. And I think this is really one of the big advances that we have now with lateral flow assays, right? So right now we are using many of these lateral flow tests, including this lateral flow assay we used in this study. We're using it with an automated reader. So it even comes, when you order this test, it comes with a cube reader that actually measures your test line intensity, right? So it gives you basically an optical density index for your test line on the lateral flow assay. So it's basically, it lets you quantify the result, and it gives you, and this is extremely helpful, obviously. It's first of all helpful to really differentiate positive from negative, because I can tell you, and we did some experiments where we just tried to read it with naked eyes to blinded investigators. And especially if it's borderline, there's always some discrepancies. And you think this is within one center, right? But once you move to different centers, it all gets very messy, because the test line for just positive is still a very slight test line. So it's hard to see with the naked eye and differentiate. And with the new, basically, cube reader, it really, you don't have to look on the test yourself, basically. You just have to let the cube reader make his work. The cube reader will also measure the control line. So it also gives you an invalid result if some problems had occurred with the test. And it really allows basically comparing the results between centers. And we have showed it before, where it was amazing. We had about 300 BL samples from 3 different centers from two different continents. And the errors under the curve were really completely interchangeable between the centers with this automated cube reader. So it really kind of like objectivizes this lateral flow assay, and I think makes it a much more valid option for diagnosing aspergillosis.
Yeah, I'm kind of looking forward to having more objective interpretation of any lateral flow assay, because if we learned anything from the COVID at home tests, a lot of questions. What is positive? Is this positive enough? So I think these sort of automated readers are the future and will really help for sure. Yeah. So we talked about respiratory samples, but you also looked at serum samples, and you reported quite a low sensitivity for serum from kappa patients. So do you want to talk about kind of what you found sensitivity-wise and why you think it is so sensitive or so much less sensitive in kappa patients versus other maybe non-COVID patients with IPA?
So I think this question really brings us back to the spectrum of aspergillosis, right? And when we go away from neutropenic patients to non-neutropenic patients to ICU patients who develop aspergillosis, I always thought that, serum galactomannan is not sensitive for early diagnosis, right? It's really not sensitive in this setting. We always proposed since many years, once you have non-neutropenic patients, you have to get a BL to really diagnose aspergillosis early. Because it takes a while, it takes several days until it becomes angioinvasive. And this is really a late stage where, much more of your patients will die. But this is not the time to diagnose it. We really have to diagnose it while it's still only growing in the airways in order to treat it successfully. And with all this background, I'm not surprised. I don't even think that the serum galactomannan has a lower sensitivity for diagnosing kappa versus diagnosing other invasive aspergillosis in the ICU outside of neutropenic patients who happen to be in the ICU, right? So I really think this is pretty much in line with that, with the exception of influenza, as I said before, because influenza is the one exception where we really saw a rather good performance from serum galactomannan in the ICU, much better than we usually saw before for serum galactomannan in the ICU. So, yeah, but nevertheless, of course, we looked into it, and there may be other future tests from blood that may also work for kappa or for other aspergillosis, for early diagnosis of aspergillosis. But in our study, when we looked into the LFA, it was pretty much comparable with the galactomannan ELISA, that the sensitivity was just not good. And potentially, when thinking about the spectrum, patients develop aspergillosis or first colonized, then this starts to grow tissue invasive in the airways, and after 8 or 10 days, it becomes angioinvasive. The fact that the serum galactomannan is positive or negative may really reflect the time point of your diagnosis, right? Are you diagnosing it early or are you diagnosing it late? If you diagnose it late at one point, of course, and if patients really develop invasive Aspergillosis disease, then serum galactomannan will be positive, right? If you diagnose it early, it's always not all of these patients may develop invasive disease. Of course, it's always kind of like an overtreatment approach potentially. But nevertheless, though you may still be early enough for treating them and for having a good proportion of your patients surviving. So I think that's always the caveat that you have to take whatever approach you choose. But I think in our cohort, probably it was lots of cases that were diagnosed early. And that's the samples that we had a hold from. Also in terms of mortality, this pretty much reflected early diagnosis. We did not have 100% mortality in kappa patients. We more were like, I think it is 60% or something like that. So, yeah.
Yeah. No, thank you. I think that was a good, a nice summary of your findings. Basically, the LFA really performed well in respiratory samples. Serum samples just not the go-to for kappa early kappa diagnosis. So with that, we'll kind of change gears a little bit and turn to Dr. Alonzo's recently accepted study where he and his co-authors really took more of a global view, I guess, at the performance of multiple different mycologic assays for the diagnosis and prognosis of kappa patients. So to start, Aljandre, can you summarize for us kind of the overarching goal for your study in particular?
Yeah, so the goal of our study was to evaluate as much fungal markers as possible, and we are able to set up a lot of different markers in our lab, as in other many labs. And so the goal was to evaluate those markers in patients at risk of kappa in our 4 ICU, in our 2 different hospitals. And indeed, we evaluated 7 fungal diagnostic tests, but no LFA. So it's nice that Martin did that specifically on LFA. And so we are not used to working with LFA, but we are in the process of evaluating those as well. So in respiratory specimens, we did a direct examination, which is clearly a wet mount of respiratory specimens using chalcofluor and looking at Aspergillus hyphae directly at the fluorescence microscope. We evaluated also culture on Saburo and malt agar. we evaluated galactomannan in BAL supernatant. So we stick to the recommendation of the manufacturer for the BAL. And we performed also Aspergillus fumigatus quantitative PCR in all those respiratory specimens, and this time on the pellet of the BAL or on the pellet of the sputum or the bronchial or tracheal aspirate. And in serum, we performed as we do for hematology patients. We performed galactomannan. We did also beta-glucan and quantitative PCR when we saw those serum or plasma specimens. So we did quite a lot of tests in our patients, with the goal to evaluate the performance of those tests and putting together the result of the test with the mortality we obtained in the end. So this was not a very controlled study, meaning that the patients were treated when it was necessary at the discretion of clinicians. So we don't have a very, let's say, a very strong power for this kind of study. It's still a retrospective study and much more observational study, but still we got from some very interesting results.
Mm. So I kind of diving into those, I guess, amongst all of the mycologic assays that you looked at, what individual assays or combination of tests that you looked at were most reliable and also kind of best for predicting mortality amongst kappa patients?
Yeah, so it was quite a surprise. So we had some tests that clearly were 100% associated with mortality. So the first one was direct examination. So when we saw Aspergillus hyphae in the respiratory specimens of the patients, all those patients died at one point. And what is also interesting is that direct examination was not the only mycological criteria positive for those patients. So systematically, direct examination was associated with a positive culture or a positive galactomannan in the BAL or in the serum, meaning that, as Martin said, for this specific criterion, you are late in the disease, and so you have a lot of positive mycological criteria, and this this correlates with an advanced disease for the patient, and so potentially a very high mortality. So there is another one that also associates with 100% mortality in our study. It was serum galactomannan and serum quantitative PCR, and so this is reminiscent to the discussion with Martin. When you have a positive serum galactomannan in those kind of patients without any risk factor of classical risk factor of invasive aspergillosis, you are late in the disease. And when you are late in the disease, it's difficult to treat the patient, or it's difficult to eradicate Aspergillus, and then it's associated with a very high mortality. So this was quite a surprise, but in the end, it's quite coherent to see that if you see a lot of fungus, and if you start to see galactomannan in serum diffusing or nucleic acids of Aspergillus fumigatus in the serum diffusing, it means that the fungal load is very high, and in the end the disease is very advanced. And so if you something very interesting, I guess, very important, something very important in this situation is you see that quantitative PCR can be very important, and galactomannan also. But one point, if you want to use those tests in real time, you have to be able in your lab to give a result in a short time manner, meaning that you have to deliver the results within 24 to 48 hours to try the clinician to identify those very special patients at risk of dying from COVID and kappa because of those positive results in the serum or using a galactomannan or PCR. So this is, I think, very, very important, and we are organized in our center to do that and to give the results within 24 to 30 hours.
So yeah, so I found the serum PCR results really quite definitive when it comes to mortality and diagnosis, but the BAL PCR and BAL was not quite as effective or clear. So can you talk a little bit about what you found there?
Yeah, so when you are dealing with PCR in the BAL or in respiratory specimens, it's clearly more complicated to interpret. And this is why you have to consider here for this specific test, you have to consider the let's say the technical things you have to start to manipulate the specimens, meaning you have to handle the specimen specifically to increase the fungal load and to have a reliable quantification in the end. And then the main point is to be able to quantify the fungal load. Mm-hmm. And to quantify the fungal load is very, very important because you need to interpret the results in the light of the fungal load you can define, you can find in the respiratory specimen. And to be more precise, in our center, we are dealing with the pellet of respiratory specimen, meaning that even if you have a very high volume of the respiratory specimen, you can still work on the highest concentration of fungi by centrifugating and by dealing with the pellet. And then you have to trust in your PCR. You have to know the PCR and the primers and the specificity, the technical and the analytical sensitivity of the PCR. And when you do that, you can rely on the quantification you get. And what we obtained is very interesting. We found that a cutoff of 32 CQ, which means if you are below 32, you have a very high fungal load in the respiratory specimens, so BAL or other non-BAL specimens. And if you have this kind of high fungal loads, it's more associated with mortality than if you have a lower fungal load. Meaning that quantifying the fungal load in the respiratory specimens can help you deciphering if the patient has a high fungal load is high risk of mortality or not. And this is clearly a way to answer the question, the historical question and the philosophical question, colonization or infection. And so this quantification is helping, of course, plus associating these results with other fungal criteria, which helps also having a better idea of the diagnosis.
Yeah, so I found quantification in BAL interesting. It's quite a challenging specimen type, right? Because you have different volumes to begin with. So I found it interesting that the CAPA criteria actually set a cutoff, which was 36. And Martin and I guess Aljandre, back to you too. I'm kind of curious where that 36 came from. Were there studies or kind of, it's an interesting concept to set a threshold with such limited data, especially given that the PCR assays can be so different between centers.
You're right. this threshold is difficult. Any threshold when you deal with fungal PCR is almost impossible to define and to be sure. Why? Because the PCR you can use are very various different. Okay, the methodology is also different. The extraction procedures are quite different also. And so in the end, from my experience with pneumocystis, we had very large differences with panel specimens using different type of PCR, meaning that it was quite difficult to set a threshold to say yes, colonization or infection. But when you know the PCR you are using, you know what is corresponding to a high fungal load and a low fungal load, even if the threshold is not, perfect. But below a certain amount of CQ, you are quite sure to have a very high fungal load, and those patients are clearly more at risk of dying of kappa.
Mm-hmm.
And
yes.
If I just quickly may jump in, what informed the decision? So basically, you're absolutely right. There's not a ton of evidence. So there were some studies from Louis White, basically, where this was based on, but this is not strong evidence. And that was the decision we had to take at this time. At the same time, it's also not that decisive, right? Because the threshold is there to kind of like make PCR a unique criterion for probable. If you don't meet the threshold, it could still be a combination criterion with another weaker criterion, right? So it's not that, a PCR, that's not meeting the threshold is useless. It can still help, if you have another test, a second test positive, to make your patient be classified as, potentially positive disease. So I think that's important to emphasize.
Got it. Thank you.
Yeah, so I think what is very interesting in this field and at this moment right now is the fact that we are talking about combination of markers, and I think we will gain specificity for those diagnoses with combination of markers, and a lot of people are used in the end combination of markers in their studies, and I think it's working.
Yeah, I think one of the other take-home points is for laboratories that are working on or developing or implementing an Aspergillus PCR assay off of respiratory fluid or any other sample type. These thresholds can be used as guides, but labs are going to have to establish their own significant cutoffs. So,
Aljandre, based on your data, how would you suggest changing the definition of kappa? If you could tweak the definition, what would you like to do?
Difficult question. No, I would consider. So one point is the type of specimen, and based on our data and the PCR data, I would suggest not to exclude the probable diagnosis in non-BAL specimens, because even if you have a non-BAL specimens, it does not mean that it's not the reflect of what you have in the lung. Also, we agree also that you increase the chance to take some spores from the environment or from colonization. But still, in these patients at risk, and in combination with other markers, I think it's important, and I'm not the only one to say that it's important to consider at least this as something relevant that can be the starting point of a complete workup of the patient. And I think this is you have to interpret also everything in kinetics, and so you can imagine to screen with tracheal aspirate, for example, doing mycological criteria, doing a mycological test, and then to do a more complete workup on the patients. Martin, what do you think about that?
No, I fully agree with you, Aljandre. Actually, I think it's I think what we wanted to do with this criteria is to have them, also relatively stringent. But I think it's a weakness that they don't allow at all for any evidence from tracheal aspiration, right? So the only thing they allow for is basically bronchial lavage or non-directed bronchial lavage, right? So I think, and that's a limitation. At least, in combination, I think, that's definitely something where once we work on updating the guidelines, we should be more open to that, because for some institutions, right, if you don't do lavage or non-directed lavage, you will never have a patient fulfilling the criteria unless it's really latent disease where, they have a positive serum and are dying anyways, right? So what is the point? I mean, you could argue even what is the point in treating them, because they're dying despite being treated, right? Of course, we would still treat them and hope for the best. But it's really, Aljandre's studies really shown us how devastating the prognosis is in these patients. And there has even been a second study from Paul Verwey, basically completed in the Netherlands, that also showed, that, specifically serum galactomannan, a very, very high proportion of those died despite antifungal treatment. So I think, being more open and also making this criteria more usable for around the world and for many other centers that are not as aggressive with doing bronchial lavages, and allowing some combination approaches, I think, would definitely be the right next step. So I fully agree here with Aljandre.
Well, it sounds like the criteria may be changing and be tweaked in the future with both of your studies. So I want to thank you both for joining us today. I think this was a really insightful discussion, very helpful for those of us that maybe don't think about kappa on a daily basis. But thank you again. Thank you to the listeners, and we will see you again next time.